about immunodeficiency disorders and autoimmune disorders. Now, it's quite a vague topic to be honest, but once we put in some effort and time into this, it's going to be one of the easiest topics to tackle. And what are we going to cover? So, we're going to talk about primary immunodeficiency disorders and autoimmune disorders such as SLE, scleroderma, and Sjogren's disease. Now, let's start with what is immunodeficiency, which basically is defective or improper functioning of the immune cells. And so the patients are going to be immunodeficient and they will be susceptible to frequent microbial infections. Now, what is autoimmune disorder? It's when there's going to be over improper functioning of the immune cells again, but then this time the immune cells are going to be activated against body's own self antigens or autologous antigens. Now, I'm going to start with immunodeficiency disorder, and I've tried classifying immunodeficiency disorder based on the type of the or the component of the immune system that is affected. So I've classified it into humoral immunity deficiency, T cell deficiency, both humoral and cell mediated uh, immunity deficiency, and then complement deficiency. Now, we're going to talk about everything in detail in the later part of this lecture. So, first, we'll talk about immunodeficiency due to defect in humoral immunity. And the first one we're going to talk is X-linked agammaglobulinemia. And in this condition, as the name suggests, there's going to be agammaglobulinemia, which means less immunoglobulins are going to be present, and it's X-linked. So, if there's less gamma globulins, we should understand that immunoglobulins are produced by mature B cells. So, if there's going to be a disorder of B cell maturation, then immunoglobulins cannot be produced. And as it says X-linked, then males are commonly affected, and the pathogenesis is mainly uh, mutation of proton tyrosine kinase, and patients usually present with frequent Giardia intestinalis and enterovirus infections, but they are usually present after 6 months because breastfeeding will provide um, passive immunity until then. And the live vaccines such as polio should be avoided for these kind of patients. The next one we're going to talk about is hyper IgM syndrome. Again, from the name, we can infer that there's going to be excess or over secretion of IgM, and this is because of monoclonal proliferation of one type of plasma cells, which is monoclonal proliferation basically. And CD40 ligands on T helper cells. So the pathogenesis is basically CD40 ligand on T helper cell is mutated, and this CD40 ligand will go and sit on CD40 receptors of B cells, and this will cause class switching of B cells. So now, because there's going to be defect in CD40 ligand on T helper cells, class switching will not happen properly, and there's going to be hypersecretion of immunoglobulin M. That is, only one type of immunoglobulins will be produced, and everything else are going to be low. And patients usually present with recurrent pyogenic infection. The next one that we're going to talk is IgA deficiency. Well, IgA provides immunity to the mucosal surface. If there's going to be IgA deficiency, mucosal immunity is going to be impaired. And clinical presentation wise, I think patients are usually asymptomatic, but recurrent viral infections can also be seen. Now, as we finished humoral immunity, the X-linked agammaglobulinemia, hyper IgM, and IgA deficiency, we're going to move to T cell deficiency, T cell deficiency, which is basically which manifests as DJOT syndrome. Yeah. So in DJOT syndrome, there's going to be mutation in 22q11 gene, and this will cause defect in third and fourth pharyngeal pouch. The so what third pharyngeal pouch will give rise to is thymus and parathyroid gland, and fourth pharyngeal pouch will also give rise to parathyroid gland. Now, because thymus is responsible for T cell maturation and proliferation, and thymus aplasia can be seen in these patients. There's going to be T cell deficiency, and parathyroid gland aplasia can also be seen in these patients. So, they eventually will have hypocalcemia as parathyroid gland produces parathormone, which increases the blood calcium levels. And on top of that, we're also going to find great vessel defects, heart, and face defects. So, we've covered T cell deficiency. Let's move to both humoral and cell mediated immunity um, defects. This manifests as severe combined immunodeficiency, um, Viscott-Aldrich syndrome, and then uh, co- variable immunodeficiency. In severe combined immunodeficiency, there's going to be impairment of B and T cell mediated immunity. So the pathogenesis involves a defect in cytokine receptor. Well, cytokines are basically responsible for T cell maturation and proliferation. And so, if cytokine receptor is impaired, there's not going to B cell maturation, and T and B cell maturation and proliferation is not going to happen. And secondly, there's going to be MHC2 um, deficiency. What MHC does is basically it presents antigens to T helper cells. Now, these T helper cells in turn will stimulate natural killer cells, B cells, and cytotoxic T cells, which is represented as CD8 positive cells. And the next one is going to be adenosine deaminase deficiency. Well, adenosine deaminase is essential for deaminating adenosine to inosine, and that will eventually be converted to uric acid to be excreted in the urine. Now, because there's going to be adenosine deaminase defect, the adenosine will start accumulating in lymphocytes, and it's toxic for lymphocytes, and that will destroy the lymphocytes. So, these patients, because of impairment of both types of immune cells, will be susceptible to frequent microbial infections, and all kind of microbial infections can be seen. So the only treatment option available as of now is stem cell transplant. Now we're going to move on to combined variable immunodeficiency. There's going to be low immunoglobulins, and pathology is again B or T cell uh, T helper cell defect. So that is why we'll be having low immunoglobulins, and clinical presentation is again frequent Giardia intestinalis, enterovirus, and bacterial infections. Now, as we've covered both humoral and cell mediated defects, immunity defects, we'll go to complement deficiency. We'll talk about complement pathway defects. Now, the complement pathway, if we'll just cover a basic idea of what is complement pathway and what are the components involved, and then move on to talk about the defects. There are three major pathways in complement pathway. There's classical, there's lectin, and there's spontaneous. Well, everything eventually leads to formation of C3 convertase, and C3 convertase will eventually again lead to formation of C5 convertase, and C5 convertase will lead to formation of MAC complex, which is membrane attack complex, which is what is going to cause pathogen lysis. And now there are defects in complement pathway, which is going to be early component deficiency, which is when one of the components of before C3 convertase is going to be defective, is when we call as early component deficiency. If one of the components after C3 convertase is going to be defective, then we call it late component deficiency. Now, splenectomy can also cause complement deficiencies. Let's see how. So, macrophages phagocytose foreign bodies in spleen. Now the macrophages, after phagocytosing them, will present the antigen to T helper cells and will eventually lead to formation of IgM and IgG. Now, because there's going to be decreased IgM, there's going to be less stimulation of classical pathway. So, eventually, splenectomy will lead to defect in complement deficiency, or defect in lead to complement deficiency. And secondly, we're going to talk about paroxysmal nocturnal dyspnea. Well, the membrane attack complex can also go and lyse RBCs, but RBCs are prevented by lysis from membrane attack complex by DAF and MERL, which is held on the surface of RBCs by glycoprotein 1. This glycoprotein 1 is coded by PGA genes. Now, in paroxysmal nocturnal dyspnea, the PGA genes are going to be not present or mutated, which will lead to reduced glycoprotein 1 on the surface, and so there's going to be less DAF and MERL on the surface of RBCs, and so RBCs are going to be more prone for attack by membrane attack complex. Now in the night, there's normally going to be reduced respiratory drive, and on top of that, there's also going to be RBC lysis, which will eventually lead to paroxysmal nocturnal dyspnea in the patients. Now, let's move on to autoimmune diseases. Before that, I want to talk about central tolerance and peripheral tolerance. So, what is central tolerance? Is the mechanism by which T cells and B cells discriminate between self and non self antigens, while peripheral tolerance is when T cells and B cells are prevented from overreacting to allergens. And then let's talk about systemic lupus erythematosus. This is one of the disorders that is mediated by autoantibodies, and the etiology is going to be genetic and environmental factors. So, now let's talk about the pathogenesis. First, environmental triggers will cause cell apoptosis, and this will eventually lead to um, the nuclear proteins being exposed to our immune system. Now, because the nuclear proteins are exposed to immune system, there's going to be the normal pathway of antigen presentation, T helper cells being activated, plasma cells producing autoantibodies, antigen antibody complexes being formed, and this will activate the complement system. And because of this activation of complement system, the patients will present with rash and nephritis, cerebritis, LSC, that is Liebman-Sachs endocarditis, photosensitivity, mouth ulcers, and serositis. But because these patients are are genetically more prone to having SLE, and also because of the environmental triggers frequently, there's going to be abnormally activated complement system that will lead to presentation of these symptoms on patients. Now, after this, we're going to talk about scleroderma or systemic sclerosis. Well, it is autoimmune disturbance of mesenchyme, and also going to be the pathogenesis is what we're talking about. So, first, there's going to be autoimmune disturbance of mesenchyme and endothelial dysfunction, and endothelial dysfunction in this case is going to cause vasoconstriction and increased expression of adhesion molecules. So this will cause a clotting disorder that causes hypercoagulability. And there's also going to be fibrosis and perivascular sclerosing of the vessels and eventually organ damage. Now, the antibodies that are present is going to be against DNA topoisomerase 1 in this condition. In patients usually present with CREST syndrome, which is basically hypercalcinosis, that is abnormal deposition of calcium in organs and subcutaneous tissue and everywhere. And the patients will have Raynaud's phenomenon as well. And there's going to be esophageal motility disorder, where one of the major symptoms that patients will have is severe recurrent GERD, which will not improve with lifestyle modifications. And then sclerodactyly, which is thickening of the skin and subcutaneous tissue. And then telangiectasia, which is widening of the blood vessels on the surface of the skin. And after this, let's move on to Sjogren's syndrome. It's basically the autoimmune destruction of parotid and lacrimal glands. And so, and also, patients will also have sialadenitis, that is inflammation of small salivary glands due to lymphocyte invasion, and which can be found in lip biopsy. And patients will also have antibodies like anti-nuclear antibodies, anti-SSA, that is Sjogren's syndrome A, and anti-Sjogren's syndrome B. Antibodies and rheumatoid factors can also be present in these patients. Now, clinical presentation for this condition is xerophthalmia and xerostomia, obviously because of autoimmune destruction of parotid and lacrimal glands. And then, because there's going to be less saliva in the mouth, the debris will not be naturally removed, and so caries can also be, patients will also have caries frequently. uh, yeah, so that's it, guys. Thank you so much for listening.